and welcome to the City Club of Portland's Friday Forum, Oregon's premier public affairs forum. I'm Sue Thomas, president of City Club, and I welcome you all, those of you here at the Governor Hotel, and those of you listening on OPB or KBPS radio, or watching on Portland Community Media's CityNet 30. Thank you for joining City Club today on Friday, May 21st for this week's Friday Forum. Today we will hear from Doctors Sanjiv Kaul and Albert Starr about how to keep your heart healthy. But first, some announcements. In consideration of those sitting close to you and those in our radio and television audiences, if you have not already silenced your cell phones, would you please do so now? As always, we offer our appreciation to our Friday Forum corporate sponsors whose generous financial support make these time-honored luncheons possible. Please join me in expressing our appreciation to our spring quarter sponsors, Key Private Bank, Northwest Natural, and Schwabe Williamson Wyatt. 60 years ago, City Club was instrumental in the creation of Forest Park. Today, this beloved park faces an accumulation of financial, administrative, and environmental challenges. Yesterday, City Club released a new Forest Park research report, which makes recommendations for addressing these challenges. We will be hosting an informational town hall to learn about the report's findings and conclusions on May 26th, and then 2 weeks from now, on June 4th, at City Club's annual meeting, we invite you to join us for a debate and interactive discussion about this report. We hope to see you all there. Next week, in honor of Memorial Day weekend, City Club will not be hosting a Friday Forum, but we again invite you to join us in 2 weeks on June 4th for our annual meeting. And now to today's program. According to the World Health Organization, heart disease is the leading cause of death in the world, even though it is often preventable with healthy lifestyle choices such as exercising and maintaining an appropriate weight. For those with heart disease, new surgical options have revolutionized care, allowing people with the condition to live long, high-quality lives. Today we welcome two heart specialists who will discuss heart disease and heart health. Our first speaker today holds many titles. Dr. Sanjiv Kaul is the Distinguished Professor of Cardiology, Professor of Medicine, Professor of Radiology, and Chief of the Division of Cardiovascular Medicine at OHSU. Prior to that, he was on the faculty of the University of Virginia for 21 years after receiving his medical degree from Delhi University in 1975. Dr. Kaul's major clinical and research interest is coronary artery disease, and he has published over 250 articles on the topic. He has been funded continuously by the National Institutes of Health since 1986 and has received numerous grants from the American Heart Association. Dr. Albert Starr received his medical degree from Columbia University's College of Physicians and Surgeons. Since 1965, he has practiced medicine here in Oregon, and like Dr. Kaul, holds many titles. Dr. Starr is a professor of surgery at OHSU, a director of Heart and Vascular Institute at Providence Health System, and is also the Providence Director of Bioscience Research and Development. He has received numerous awards and honors for his work, including the Distinguished Scientist Award from the American College of Cardiology and the Albert Lasker Award, one of the most respected science prizes in the world. We are extremely pleased to have two such esteemed scientists with us here today. Please help me welcome to the stage today's speakers, Doctors Sanjiv Kaul and Albert Starr. Doctors?
Well, thank you for your very kind invitation to come to the City Club. The last time I was here was about 30 years ago, and so a lot has happened since then, the golden years of cardiac surgery. I'd like to start out, we're going to have a dialogue between the two of us, and I'd like to start out with just some general considerations, and then we'll get to a spirited discussion. And that is that the enormous increase in life expectancy that occurred during the 20th century. At the start of the 20th century, the life expectancy was about 50 years of age. And during the 20th century, it went up to 78%, 78 years for men and 80 years for women. And this increase in life expectancy has been related to many factors and important medical care advances. And in the first half, it was mainly hygiene, vaccinations, proper nutrition. In the second half, it was due to organized medicine and medical care. And if we look at what happened to the life expectancy after, in the middle of the 20th century, the life expectancy of women went up faster than the life expectancy of men between 1950 and 1980. And then in 1980, men caught up. And the reason why they caught up was the effective treatment of coronary artery disease, which is the #1 cause of death in males, and which occurs earlier in the life of a male than it does in the female. So that's just a general point that I would like to make. Now, the mortality rate for heart disease dropped from 400 deaths per 100,000 population to about 200 deaths per 100 population, at least half. Mortality rate from heart attacks also dropped dramatically from 345 deaths per 100,000 population in 1980, not too long ago, to 187 deaths per 100,000 population in the year 2000. And this is despite the increase in obesity, diabetes, lack of exercise, and hypertension. So despite all of these risk factors that we're going to discuss in our conversation, we still have had an enormous advance in the treatment of heart disease that resulted in these demographic issues. Now, the total cost of the treatment of stroke and coronary artery disease is estimated this year to be $500 billion. And the total cost for the treatment of cancer, for example, is about half that amount. So we're still putting a lot of our resources in medical care. Now, one thing I'd like to bring up, and it's very rarely discussed, is the value of medical care. So not the cost, but the value. And in 1965, Kevin Murphy, an economist, won the MacArthur Fellowship Genius Award for the concept of the value of a statistical life. And ordinarily, we think of the value of something as what it cost. But the value of medical care in terms of increasing longevity and quality of life is not until until Kevin Murphy worked on this, was not even considered. And so we have some really interesting numbers about that. What he did was he calculated the value of a statistical life, because you cannot put a value on a single individual's life. And using market-oriented techniques, for example, hazardous pay, the increase in compensation for hazardous pay with a certain mortality rate associated with a job like coal mining, or safety devices and what they cost and how many lives they would be expected to save. So you can put a market value on life called the value of a statistical life, or VSL. And it comes out to about $6 million per person. And you could also calculate it on the basis of per year, what it's worth per year. And I'd just like to read you some numbers which are absolutely staggering. And that is that the increased life expectancy between 1970 and 1998, which was a significant increase, added $2.6 trillion to the national wealth per year. 2.6 trillion. Progress in the treatment of heart disease alone contributed 1.1 trillion of those gains annually during that time. And if we look ahead, if we could reduce the mortality of the cardiac mortality by 10%, it would have a present value of $5.5 trillion for future generation. So it's a concept, and we can't take it too literally, but I think it's really important in considering healthcare to look at the value and try to put a number on it if possible, rather than the cost alone. And we can go further and say, where do these gains come from? 1/3 is due to the invasive treatment of coronary artery disease, which we will discuss, stents and cardiac surgery. 1/3 are due to new drugs, statins, and antihypertensive medication. And 1/3 is thought to be due to changes in behavior. And so these aspects will be the basis for our discussion today. Now, I'd like to just mention Oregon and its distinctive features in the area of heart disease. And there was a very nice report by the Center for Disease Control in 2007, and it showed these characteristics for our state. There's a higher incidence of stroke mortality compared to the national average. This is a big problem which we will address. There's a lower incidence of coronary heart disease mortality than the national average. Oregonians are healthier than the average American. And interestingly enough, the mortality of coronary artery disease is down 30% between 1996 and 2006. So in the past 10 years, there's been a significant reduction in the mortality of coronary artery disease. I think thanks to the great work of our cardiologists and cardiac surgeons in this area. Interestingly also, there's an uneven distribution of coronary heart disease in the state. Some areas have higher incidence than others. And there's a peak on the coast and in Central Oregon for mortality rate from coronary artery disease. The Oregon citizen continues to have increasingly elevated cholesterol levels as compared to previously. The incidence of high blood pressure is about the same, and the total cost in Oregon in 2006 to take care of cardiovascular disease was $1.2 billion. The cost of medical research nationally is about $120 billion, of which about $10 billion goes for the treatment of the research in heart and stroke. And the philanthropy provides about 7% of philanthropy goes to the medical system, all the rest to other parts of our economy. I'd just like to give you a higher education analogy in considering the role of philanthropy in medicine, and that is that in 2005, the total cost of higher education was $391 billion. The government paid $41 billion, tuition paid $33 billion, and philanthropy provided 26%, or a total of $103 billion for higher education. And contrast that with the much less contribution of philanthropy to medical care. So now I'd like to switch over to the history of cardiology and cardiac surgery in this community and where we've come over the past 30 or 40 years, and perhaps start out with birth defects. The heart is a complicated structure, starts out as a straight tube, folds on itself into a helix, develops into a complicated structure, and defects can occur. And here in Oregon, we have been pioneers in the treatment of pediatric problems, ventricular septal defects, atrial septal defects, various complex abnormalities. Then came, with experience in operating on children, we developed experience in operating on valvular heart disease. The first successful mechanical heart valve was implanted here in Portland, Oregon. In 1969, we went on to doing coronary bypass surgery, and that's been one of the most effective, greatest operations ever devised. I mean, we have in the U.S. we reached a peak of about 600,000 of these operations done a year. No other operation was ever done in that magnitude. The work of the cardiologists in providing stents for coronary artery disease dropped that, but we still do about 400,000 coronary bypasses a year in this country. And I think this accounts for that improvement in the life expectancy of males, as I mentioned before. Also, in the early days, we began to attack congestive heart failure with various methods. We used the latissimus dorsi muscle, wrapping around the heart, trained it to beat on a regular basis synchronously with the heart. And we also looked into removing various non-functional parts of the ventricle and bringing it together and making it smaller. But at any rate, these were some of the historical elements in this, as I mentioned, golden age of cardiac surgery, much of which occurred here in our own community. And, but a lot has happened medically in this area from the historical point of view. And I'd like to ask Sanjiv if he could expand a little bit on that.
Yes, thank you, Albert. As most of you know, Albert was the first one to replace a valve in any human, and created this entire field of valve surgery, and also heart transplantation and congenital heart defects and all. And so cardiac surgery peaked at one time when there were really no other many options. When I was born, the drugs were digitalis and some diuretics. I mean, that's all what we had. We had aspirin, but we didn't know how important it was till much later. And then we started getting newer forms of diuretics, and then we got beta blockers, which were anti-anginal. So we could start treating angina with medicine instead of surgical procedures. And this was in the 60s. And in the 70s, we got ACE inhibitors with which we could control blood pressure much better. We couldn't control blood pressure. We used to watch people just sort of keep going. And we didn't have any power, really. And then pharmacology has changed everything. And then, of course, in the 80s, the statins came, and we can finally get people's cholesterol to about 5 points of where we wanted. Before that, we couldn't do much. And so there's been a tremendous advance in medical therapy. Also, what's happened is that we have been able to follow the surgeons with catheter-based techniques. So lots of the holes that Dr. Starr would have to operate on before, we can now close with devices that we put in through catheters through the groin or the arm. So cardiology became more technical. And a lot of the things we're going to discuss later on, he's going to start with a surgical perspective, and I'll tell you how we do it today with less invasive procedures. So balloon angioplasty was started here at Oregon by a gentleman called Charlie Dr. He wasn't using a balloon, he was using wedging the obstruction. And it sort of didn't become popular till later on somebody devised a balloon and a way to do it. But it was done here. Coronary angiography, which is the way to put dye in the coronary arteries and see where the blockage is, was started here by a guy called Judkins. So Oregon has had a lot of historical leadership role in these methods. Also imaging, which is, we used to be able to basically, we used to know what went wrong with somebody after they died. We would have to do an autopsy. And not a very convenient way of taking care of people. But the imaging techniques we have now that started developing earlier on, we can give isotopes to measure blood flow to the heart muscle with precision. We can do ultrasound or echocardiography, which is real-time pictures of the heart, which we can literally see the heart beating and all the structures in and out. And we can do MRI and look at very complex holes and abnormalities in the heart. We can do CT angiography now. We can look at the coronaries without having to do a coronary angiogram. So all these technological advances has allowed us to become better diagnosticians and also be able to detect disease early on before people become symptomatic.
Yes, and of course we piggybacked on these advances in cardiology because, for example, if we were to repair a heart valve and we didn't have at that time echocardiography, we wouldn't know until after the operation was done how effective the treatment was. But with intraoperative echocardiography, we could look at the heart just before we go on cardiopulmonary bypass, and then we could look at the heart when we finished the operation, and we can see exactly what we've done. So that was intraoperative echocardiography was a very important part of advances in cardiac surgery. And also the advent of MRI of the heart. The X-ray pictures were okay, but the MRI shows the anatomy exactly as it is. it's a great picture for a surgeon to look at before an operation. For example, if a patient had previous surgery and the heart's very close to the breastbone and adherent to it, and we go through the bone the second time, we could injure the heart. The MRI shows precisely how much space there is between the bottom of the breastbone and the beginning of the heart, so we could avoid injury. So the advances made in cardiology have made surgery infinitely safer than it was.
So risk factors. So, you know, I'm a firm believer of risk stratification, but only if we can risk manage. So we know, for example, that high blood pressure is a risk factor for stroke and for heart disease. But if we can't manage it, then it's, you know, you feel pretty impotent. Now what's happened is almost all risk factors that we know of can be managed very accurately and with a great degree of success. Hypertension. 1 out of every 4 Americans has high blood pressure. Okay? Leads to all sorts of problems. Stroke, disease of the eyes, kidneys, and heart attacks. So we can control blood pressure, and there is no such thing as borderline high blood pressure. Let me make that point. It is either high or it is normal. Okay? I am fed up of patients telling me they have borderline high blood pressure, which is... So, blood pressure, cholesterol. Cholesterol is a biggest Scrooge in our society. And it is partly genetic and it's partly, of course, our own fault. We are born with a cholesterol of about 35. And by the time we become adults, it's usually over 200. And so we can bring the cholesterol down to literally where we want it with the types of drugs we have. So that's another risk factor management. So the important thing is to remember that things that tend to kill you or cause heart disease can be managed so that you never get heart disease. So you don't need to see Albert Starr. Okay? So,
which is okay.
So we have to, so we can get the cholesterol down. Cigarette smoking. It's been a huge public health achievement. After the Second World War, 65% of Americans smoked, now 20%. Okay? Smoking, it's been a great achievement. On the other hand, we have things that are, okay, diabetes, huge risk factor. In fact, people with adult onset diabetes do not die from diabetes. Nobody dies from high blood sugar anymore. They die of heart disease. Okay? So diabetes control is extremely important and easily doable. There are lots of medications now that are available to control diabetes. And finally, obesity. All the gains Albert has talked about will all be reversed if we allow this epidemic of obesity, because with obesity, it's associated diabetes, hypertension, and heart disease and everything else. So if we can keep our weights down, I don't know for a drug for obesity, unfortunately. There are some things that you can do, you know, you can take drugs, but they're not very effective. The only thing effective is to just keep walking and keep exercising. And so some part of our responsibility towards our own health comes from trying not to smoke. There are certain things we can't help, okay? But if you don't smoke, if you eat right, Albert asked me, what are the advances made? What would you say as a modern cardiologist to people? I said, I will say what Maimonides said in the 7th century. He said, eat the right things, exercise a lot, and keep away from melancholy. Or melancholia, that's what he said. Keep away from melancholia.
Don't get depressed, right. Could I add this about diabetes? And that is, we could really be proud in Portland because we developed a technique of dealing with diabetic patients that's called the Portland Protocol. If you Google it, you will find it. It's used all over the world. And it started here in Portland, Oregon. And what it was is this, that when we operate on somebody that has diabetes, their mortality rate is at least double what the baseline rate would be for non-diabetics. And what we discovered was that with the patient in the hospital, and in the intensive care unit especially, we could monitor the blood sugar very aggressively, frequently, and with insulin drip intravenously, we could keep the blood sugar at normal levels, that is under 100, which would be dangerous for an outpatient doing it himself, but which is perfectly safe in the hospital. And what this did was it reduced our operative mortality for coronary artery surgery and other cardiac operations in diabetics back to the normal expected mortality of someone who was not a diabetic. And this concept of keeping the blood sugar as normal as possible has spilled over into other areas of surgery, including eye surgery. People have diabetic retinopathy, and there's some new procedures for that, and even at that time, they should have their blood sugar monitored carefully, and they could achieve a baseline mortality rate rather than the markedly increased mortality rate if they have these operations as diabetics without this kind of protocol.
There are some new drugs that are coming around also that we would like to highlight. There are drugs, you know, the cholesterol crosses the wall of the artery to enter the artery, and we have drugs to lower cholesterol, but there are drugs being developed that will even prevent the entry of cholesterol into the artery. There are vaccines being developed that prevent atherosclerosis from developing. So these are all futuristic, but these are things that are going to help fight coronary artery disease.
Yeah, that's a very good point, because we see patients with very high cholesterol occasionally who have no atherosclerosis. Their arteries are normal. Well, how come their cholesterol is so high? We know there are other factors that allow cholesterol to get into the blood vessel wall, not just the level of cholesterol in the blood, but the permeability of the inner linings of the vessels to cholesterol inflow. And the wall of the artery is protected by proteins that have just been identified this year. And so the pharmaceutical industry is now heading as fast as they could go to developing methods of enhancing that protein barrier that keeps fatty material from getting into the vessel wall. So that's a very important new area. Plus, you might mention the role of inflammation and how elevated C-reactive protein can lead to atherosclerosis.
Yes, so atherosclerosis is basically cholesterol gets into your arteries, and then the body mounts an inflammatory response. Cells get in to try to take care of the inflammation, and your certain protein markers in your blood go up called C-reactive protein, which has also become a risk factor that we are looking at. So even if we find people with normal cholesterols whose C-reactive protein has gone up, we find that that cholesterol is too high for them, and we try to treat it.
Oh, also, could you mention the targeting anti-cholesterol drugs to lipoprotein A, the small, how that's been identified just recently?
Yes, so lipoprotein little a is a risk factor, and it is, you'll see a lot of, okay, so there are a lot of people who will have heart disease without the risk factors I've talked about. So we are always looking for more risk factors, and one of them is a cholesterol abnormality called lipoprotein little a, except we don't know how to treat it too well. We don't have specific agents, and so there are now some drugs being developed to treat lipoprotein little a, and also to get your HDL up. HDL is your good cholesterol. So now there are drugs being, right now you take niacin or something like that, but there are certain drugs that are going to be very specific for raising your good cholesterol.
So these are very important features. And so what about now going to the problem of early detection of coronary disease? And we know that sometimes the first symptom is the last symptom.
Yes.
So could you describe that?
Yeah, I think this is an extremely important point, and in an audience that is sophisticated like here, it is important to understand that most of coronary artery disease is silent. So please don't wait for symptoms to develop. The first symptom could be your last symptom, and it's called sudden death. 50% of people who get a heart attack die before they reach a telephone. So, and people who die from heart attacks or get heart attacks, need not have very tight narrowing of the artery. All they need is some atherosclerosis that ruptures and a clot forms. Okay? So it is very, very paradoxical to me that for diseases that they're important, but there are all sorts of screening tests, but they're not as important as heart disease. For example, and I'm not trying to be politically incorrect here, but breast cancer, from which a woman is much less likely to die than heart disease, you get mammograms, screening. You get cervical cancer, pap smear screening. Men get their prostate levels screened. None of these things is going to kill most of the people in this room. But there is no colon cancer. After 50, your insurance company will give you a free colonoscopy every 10 years if your colon is normal to prevent early detection of colon cancer. But we don't have anything in our entire healthcare armamentarium where we have said if you turn 45 as a male or a 50 as a male, 50 as a male and 55 as a woman, you must go and detect if you have coronary artery disease. So remember, people always think symptoms, then they'll get a symptom and they'll ascribe it to something else. This is just indigestion, or I just have some backache, or you know what. So the important thing is you can develop coronary disease and you can die from coronary disease with no symptoms. Okay? Coronary disease is much more likely without risk factor to occur after you're 55 as a female and 50 as after you're postmenopausal as a woman. Estrogens protect women, okay? But after that, it's gone. Insurance is over. So I think the important thing really is to seek methods for early detection, okay? The regular stress tests that people do in the offices are not good. The stress test has to be done with some form of imaging. Or you can get a CT angiogram or something else, and that's between you and your doctor and your cardiologist. But it is important that you get evaluated for coronary disease because it is much more likely to be harmful to you than anything else.
Oh yeah, that's a very important element because a stress test alone, I agree, a stress test alone is not a suitable way of screening out coronary disease. And in my own personal life, and I don't mind saying this, I had coronary bypass in 1974 by my own surgical team. And they kept me alive. They liked me, I guess. At any rate, I passed the stress test, and it was completely normal. And the cardiologist at that time said, you don't have to worry about coronary artery disease, but I knew the symptoms, and I insisted that they go further, and they did a stress test with visualization and the coronary arteriogram, and sure enough, I was a candidate for surgery. So having the proper screening is really a very important part of being treated at the right time.
Do you want to talk about sudden death, Albert?
Oh yeah, that's a good idea. So, this brings up the modern treatment of coronary artery disease and how a hospital is set up to receive patients that are having a heart attack, and how the mechanism has developed that enhances the treatment enormously so that the mortality rate from heart attack has dropped tremendously. Once you hit the hospital, the mortality rate is around 5%. So this has been achieved by an extraordinary amount of coordination of care. And perhaps, Sanjiv, you could mention how the cardiologist now handles the situation, and then what role the surgeon might have to play if necessary.
Yes, so heart attack symptoms, when somebody has a heart attack symptom, the ideal treatment is to get them to a hospital with a catheterization laboratory so that coronary artery can be opened with a balloon and then a stent placed. This should be done within less than 90 minutes according to guidelines. And so as a state, we have been working together between different groups to try to achieve this. And the idea is to get somebody from the field directly flown into or transported directly to the cath lab, and they in the field can activate the cath lab. The cath lab is a pretty complex thing. There are technicians, there are nurses, there are doctors, the cameras have to be working, you know, and this is 20, people don't die from 8 to 5, you know. So it has to be all the time. And so you activate the cath lab, people like myself and others who may be in bed will get up, answer the page, be in the hospital by the time the patient arrives. And this has really revolutionized the results, because the earlier you open the artery, the less muscle damage there is from the occlusion, from the clot. But if you cannot reach, if your estimation is that you cannot reach within 90 minutes, then you must get a clot buster and open the artery by busting the clot, because the clot buster is not as effective as opening the artery mechanically. But at least we know that at over 90 minutes, that is an option. But you shouldn't be waiting and waiting and waiting to get to a cath lab when you can be opened with an artery. There are new advances in heart attack treatment. After the heart muscle is damaged, now we are doing trials, including at OHSU, where we are giving stem cells. Stem cells are cells in the body that are not normally present in the different tissues in the body that have the potential to turn into different types of cells. You know, we each start with one cell, then divides and becomes the whole organism. But that one cell has the whole information for life. And it can then divide into different parts of the body. So stem cell is almost as close to being that kind of cell. And it's present all over the body to repair and do things. Unfortunately, it's the same cell that becomes cancerous. Okay? So you don't want your stem cells to be too active. But you can give stem cells extraneously into a heart muscle that is damaged, hoping that those stem cells will regenerate the heart muscle. So there's a lot of research being done on this. We are doing a lot at OHSU and in our primate center. And also there are some clinical trials for stem cells being done currently.
But this, of course, is still experimental. We don't know what the long-term results are. We do know this, that if you tie off the artery of a primate in the experimental laboratory and produce an infarction, and then 5 or 6 days later you inject the animal's stem cells into that area, that the amount of recovery of heart muscle is greatly enhanced. And those are controlled animal experiments. Whether that will be the case in man, no, we're still not certain, but it's certainly worth the investigative process, because sometimes so much heart muscle is lost during a heart attack that the patient then will never lead a normal life and perhaps slip into a congestive failure type of situation where they're greatly limited and may need further procedures. So this brings us to the area of stroke. We might mention the emergency treatment of stroke. And you mentioned TPA as a clot lysis agent. And strokes, 80% of them are caused by a clot in a brain artery. And only about 20% are due to rupture of an artery and bleeding into the brain. So the importance of a clot in the artery is now well known, and how are you going to deal with it? And as I mentioned, in Oregon, the mortality rate from stroke is greater than the national average. And so we now have a new program in Oregon called the Telestroke Project. And this is a consortium of multiple institutions around the state. And there's the hospitals, outlying hospitals are required to have TPA, or the clot-busting drug, available in their emergency room. And they could call into a central phone number and have a stroke doctor on the line. They have a robot with a camera located in each one of the outlying hospitals. And the neurologist, the stroke neurologist here in Portland, can examine the patient in Bend or in Seaside or wherever the robot is, and see the patient, talk to the emergency room physician, make the recommendations with regard to whether to use the TPA or not. And that will be a major step in reducing the mortality rate and the complications of stroke. In those tertiary care centers, like OHSU or Providence St. Vincent Hospital, with the interventional cardiologist or neurologist can actually put a catheter up into the carotid artery and pull a clot out. And we've seen dramatic return of mental function after that's done. It has to be done within the first 4 hours of a stroke. So it's not available to every part of the state, but certainly here in Portland, our ability to reduce the morbidity and mortality from strokes has increased enormously using these aggressive techniques. So let's go on to rhythm disturbances. Sanjiv,
Okay.
why don't you...
So basically there are rhythm disturbances in the heart, okay? You are born with some bypass tracts or some other electrical misconnections in the heart. And in the old days, the surgeons would have to open the chest, identify these communications with electrodes, and then cut these communications surgically. That has advanced now where we can do this by catheters. So we can put a catheter up into the heart and ablate these different things by using radio frequency energy. One of the biggest rhythm disturbances that this audience should be aware of is called atrial fibrillation. Atrial fibrillation is top portions of your heart sort of start fibrillating instead of contracting normally. And why it is important is that it is a very common cause of stroke, and it increases with age. So over the age of 65, about 3 to 4% of people are likely to develop atrial fibrillation. And if you are over 80, which is now a very common population that I see, the incidence of atrial fibrillation can be 6 to 7%. And once that happens, the heart starts doing this, you can form clots, and those clots can go and cause stroke and other problems.
Right, about 20% of strokes are associated with atrial fibrillation. But I think we have to get on to another topic which is really important, and we're going to be running out of time, and that is the problem of congestive heart failure.
Yes.
And this is a great new area that's being attacked by a combined multidisciplinary group involving cardiologists and cardiac surgeons working together. And why don't you describe what this has meant for patients?
Congestive heart failure is basically the heart muscle not working properly anymore, and it's the common final pathway of all heart diseases, okay? And it is 5 million Americans have heart failure. And the 1-year mortality of end-stage heart failure is almost 70 or 80%. And the best treatment for it is heart transplantation. And we do that at OHSU. In fact, Dr. Starr started it at OHSU. And the problem is that there are 500,000 patients ready for a transplant, but we only have 2,200 hearts available in the country because of whatever reason. So we have not seen this grow. And we don't have animal hearts ready yet for immunological reasons. So artificial hearts or heart pumps have become available. And now they've become so small that you can put it in the chest that sucks the blood from the heart and puts it in the aorta, acts as a pump. And the battery of it can be put in a little purse. And you can be walking around in town and nobody would know that you have this device. And we have this year alone at OHSU put 30 of them. And this is going to revolutionize heart disease because we will finally have options to give to people who are terminally ill with heart disease rather than waiting for a heart transplant. And most of those people die because they don't get a heart transplant because of no organs. We've also found that if you put these devices early on before they really become sick, it gives the heart rest. And then you can take them out and the heart has come back to its normal level. So instead of allowing the heart to get worse and worse and worse over time, you can give these devices early on, let the heart rest and recover. And this is exceedingly exciting, both for both of us who have seen a lot of heart failure and have felt pretty hopeless about this situation before, that now the technology is such that we can have these small pumps, and these are really revolutionizing cardiology today.
Well, it actually is revolutionizing cardiology by utilizing surgery. So the cardiologists have been playing with congestive heart failure for decades and not making a dent in the mortality or morbidity from that problem, but just a simple non-pulsatile continuous flow device, small, easily implantable, can save their bacon and the patient as well.
So the moral of the story is we'll still need surgeons.
Good. Thank you very much, and we'd be happy to answer questions.
Well, I don't know about you, but they've definitely got me thinking about some things here. The first question for our speaker, as always, will be from our City Club host. Our host today is Barnes Ellis. Barnes is a partner at the law firm of Stoll Reeves, where he practices business litigation, and since January has been part-time general counsel at Mercy Corps. Barnes previously served as a member of the City Club Board of Governors, and he is once again, right now, and is on 2 study committees relating to city governance. Barnes?
Well, first of all, thank you both. I've had the privilege of knowing both our speakers before today, and they were excellent. Now, my question is going to be designed to take you a little out of your comfort zone and talk about the intersection between medicine and politics a little bit. And here, this relates, Dr. Cole, to your discussion of risk factors, and specifically obesity and diabetes. And here's the question I would ask. Now, the American Heart Association recently published a scientific statement on sugar, using the term broadly to include all sweeteners. And it said that America had to dramatically cut down on intake of sweeteners because they raise the bad LDL and they lower the good cholesterol. So, and they specifically focused on sodas as being about 1/3 of the source of the excess sweetener in our diet. So my question to each of you is, would you favor a sweetener tax or a soda tax to try to intervene more aggressively than just an education program to cut down on the excess sweetener intake?
What gives me the hard one to take, yeah? Yeah, that is true. Let me just give a little background on this. In the 60s, the federal government got very interested in reducing fat from the food. You know, you saw labels on food, no fat or low fat, but instead they allowed the food industry to put in sugar. Sugar is worse than fat. I'm telling you, you can have some butter, you can have some butter, but don't have some sugar. Sugar causes your insulin to go up. Insulin is what puts everything into cells, including fat. So the moment you eat sugar, your insulin goes up and it puts nutrients into the cell, fat cells, and the fat cells grow, 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 grow. And the bigger they grow, the higher the LDL and lower the HDL. So if you keep away from any form of refined sugar, you are going to be much healthier. I personally never drink pop. My wife is here and she will attest to this. Drink water or wine.
But wine has sugar. Okay, but Sanjiv, you didn't answer the question completely, because the question was not whether sugar is bad or not. The question was, would you tax the use of sugar or not? And of course, there were political implications in the question.
Where would the money go? If it went to OHSU, yeah. I would tax.
Well, that's a good rejoinder. In general, though, I think that through education rather than taxation, that would be my motto: education rather than taxation. That's how I would answer the question. I would not tax, but I would certainly let people know. And also, I think in exposing children to pop, I believe the schools can regulate the availability of high sugar content during the school day, at least. And the parents should know what they're getting into by allowing their child to have too much sugar. Okay, we're ready for any other questions from the floor. Yeah.
We'll now take questions from the floor. Asking questions at Friday Forum is a privilege of City Club membership. When you ask your question, please identify yourself as a club member and ask your question in 30 seconds or less. Or give your question to a City Club member and then they can ask it for you.
Ted Kay, City Club member. Question about risk factors. I enjoyed our lunch today, and I'm wondering the extent to which it raised or lowered my risk factors for heart disease. Full disclosure, I didn't finish all of my vegetables, and I had both a cookie and the triangular brownie.
Most of the cookies are made with saturated fats, not good for you. Fat and sugar together is lethal. So if you're going to eat a baked potato, eat it by itself and with some broccoli or something, don't eat it with steak. If you want to eat steak by itself and don't put any potato next to it. Eat it with a salad. I mean, in any case, the brownie had some chocolate, which may have been of course, this is very low cocoa content, but if you have over 70% cocoa content in chocolate and very little sugar, it's good for you. Almost anything else on that plate is probably not good for you. Having said that, little bit of anything is fine. It's just when you eat the big cookie. I mean, have you seen how the cookie size increases?
Right. Okay.
I've been in this country almost 35 years. Cookies used to be this big.
No, I think that's true. I'd like to amplify that point because I put a lot of my patients on what I call the half diet. In other words, instead of giving them a complicated set of things to remember about this food or that food, whatever you see on your plate, half of it is more than enough for you. And actually, if it's a generous portion, a quarter of it is enough. But you could at least start out by having half, and then you'll find after you've done that for a few months, you could cut down to maybe a third or a quarter of what the usual portion is.
In Ted's defense, I saw that the triangle looked like a half a brownie. I'm Paige Lambert, City Club member, and my question is there any correlation between the depression or lack of sunshine? You said that Oregon has a lot of stroke, and I wonder if maybe that's what's eating away that protein, or if there's...
Well, that's a good question. And it's coming to the fore in medical research, and I have to confess that I never took vitamin D until I read some of the recent research, and I think that a certain amount of sunshine is important to your general health, and also in cardiovascular disease, and we don't get enough in Oregon, at least in the Portland area, in the valley. So I think that having a small vitamin D supplement is a smart move in addressing that issue that you just discussed. What do you think, Sanjiv?
Yes, half of my patients have low vitamin D levels. It's good to get it checked because vitamin D is a fat-soluble vitamin. Once you have taken it, if your body doesn't need it, it stores it.
Yeah.
And that can lead to complications if you have too much of anything that's fat-soluble. So if your vitamin D is normal, you don't need it. But if it's reduced, you can have it. In answer to your question, I don't know much about the relationship of depression with stroke, but I do know about coronary disease, heart attacks, and depression. Depression is a very important risk factor. Anxiety or stress is, if you are stressed, depending on how you define it, you are 4 times more likely to have heart attacks than if you are not stressed. And the mechanisms are very complex, including humoral responses, including nervous control of your coronary arteries, and so on and so forth. So if you are and most of modern stress is not even, you're not even aware of. If you told, I can tell you, I go to New York City and everybody's stressed. But they don't think so. They think when you come here, what are you guys doing? You're so boring. But you know, stress is so much a part of our lives that we don't notice. But if you stop and become self-aware, that itself cuts down stress. Dr. Starr told me, we were talking about it the other day, and he said when he got his heart attack, now that he's talked about it, it's out of HIPAA and I can talk about it. he changed his life. He would not rush. He used to rush to the airport 5 minutes before the plane. Now he gives himself an hour. So I think once you get the self-awareness, you can reduce your stress. And I think that's very important. Depression after an event. For example, if I get a heart attack, I'm likely to be depressed. And if I'm depressed, my mortality is going to be higher. So treating depression in a patient with heart disease is very valuable.
Right. Yeah, I agree with that.
Karen Curvin, City Club member. You made a comment, one of you made a comment earlier that there's no such thing as borderline high blood pressure. So please tell us, what is high blood pressure, or how high is high?
Yeah.
120/80 is acceptable. Anything above that is not.
What about 135/80 in an older person?
No, I don't like 135.
But the
Yeah. It used to be said that older people, you could let their blood pressure go up a bit. I never believed it, and now there's a huge study, multi-center study showing every point increase in blood pressure adds to your mortality. It doesn't matter what age you are.
Yeah. Kurt Wabering, member. I was interested in your comments about early detection and that normal, if I understood right, normal annual tests by your doctor, which I guess would include things like blood pressure and such and heart rate, is inadequate. And you're proposing a stress test, which treadmill kinds of tests?
Yes, but with additional diagnostic tools. In other words, during stress, you would check to see if there was an area of heart muscle which was not getting enough blood supply.
So you get isotope injections, either it's called nuclear tests, or you can do ultrasound during stress, where you're looking at the heart in real time, seeing how it. Those are much more effective in detecting disease during stress than just the EKG, where they just attach an EKG and you go on a treadmill. Obviously, if you go on a treadmill for 15 minutes and your EKG is normal, you are much less likely to have disease. But most of my patients don't go for 15 minutes. So they go, 7 minutes, 8 minutes, huffing and puffing and, all that kind of stuff. And it's not the information is not very conclusive without imaging.
I think the takeaway is to very aggressively be checked for coronary artery disease, since in such a large percentage of patients, the first symptom is death. So while you're alive, it's really good to lean on the physician to go through the whole steps that are necessary to really exclude the presence of coronary disease.
Scott Wise, City Club member. My question is, how effective do you think a vegan diet is to preventing stroke and heart disease?
Well, it's been shown, what's the name of the guy in San Francisco? You know the cardiologist? He's got diets named after him. I'm forgetting. Yes. Ornish showed very early on that if your diet is free of any animal fat, in fact free of any fat, that your cholesterol goes way down and your coronary narrowings regress. So a vegan diet in an average person is very beneficial, okay? Having said that, there are some people with a genetic predisposition of making abnormal cholesterols, no matter what they eat, even if they don't eat. And so those people have to be treated. So I think if you're a total vegan and you meditate and you're a Buddhist, you're going to live long.
My name is Maria Everhart, and I'm a City Club member. And I'm an early childhood researcher, so my question is about the melancholy that you said we should avoid. I'm familiar with a great deal of research from the Centers for Disease Control that can connect early childhood experiences before 18 for sure, and often before 8, almost perfectly in a bar graph, stair-step kind of way with heart disease at 40 or 50. And so I'm wondering how far back your institutes are thinking about prevention.
Yeah. Yeah, that's a good question, and I'm usually called later on in the disease process, so I have to punt that over to Sanjiv.
Okay, I think you have a very important point. In fact, I will go even beyond your point. It's been shown that you can predict the people who will get heart disease by the nutrition of the mother. So it's been shown in a number of societies, the Finnish, the Indians, the Chinese, right, and even some studies in the US, that if you are born small and you remain small compared to your peers, so I mean you grow, but you are still a small person overall, body mass index, you will not develop heart disease. But if you are born small, and then between the age of 2 and 13, you start gaining weight so that you are no longer on that tangent, but are now moving towards the other tangent, you are much more likely to develop diabetes, hypertension, and heart disease. So you are born with a certain vascular size meant for your whole organism. If your cells get bigger than that vascular size, you get what's called the metabolic syndrome, which is hypertension, diabetes, obesity, and then coronary artery disease and hyperlipidemia and all of that. So the same can be said after birth. So if you have children who are obese, we know that in the Korean War, young soldiers who died, 20% of them had atherosclerosis.
Yeah, I was going to mention that because I was in the Korean War at a MASH, and that's where the prevalence of atherosclerosis in 17 and 18-year-old people was discovered.
And I think in the later wars in Vietnam, it was even higher because our diets had been changing. Right. So I think if your question is childhood, I think that's where you start. Mm-hmm. And it's so unfortunate, you know, because if we eat badly, our children eat badly. And when the children eat badly, it becomes a habit. It becomes a conditioning that takes for years to decondition or uncouple. That's why the parent is so important. If the parent is healthy, the child is going to be healthy, despite peer pressure. Mm-hmm. So I think that's something that's very important.
Right.
Well, we've come to the end of our time for this week. Please join us on June 4th for a discussion about the future of Forest Park and a vote on the Forest Park Research Report. As we close, please join me in expressing our appreciation to today's guests, Dr. Sanjiv Kaul and Dr. Albert Starr. We're adjourned.